Otherwise, patients should be admitted and diagnostic studies should be sought. Initially, before the GI specialist is there, you might try putting an NG tube. NG tube can help you aid the localization. For example, you might see an output of fresh blood or the coffee ground by yourself, which will tell you if the patient have an active or a recent upper GI bleeding. But if they don't have blood in the NG tube, this does not exclude upper GI bleeding. It's not that sensitive. Now we go to the diagnostic studies. For upper GI bleeding, the diagnostic study is the upper endoscopy. And recent guidelines, again, the same guideline, and it was even recently updated in 2021 May. You should do an upper endoscopy, or the GI specialist should do an upper endoscopy within 24 hours of the patient's presentation. And there are some clinical tips. For example, if there are severe bleed, they might do a gastric lavage. Also, they might give a pre-endoscopic erythropoietin, which will reduce the need of repeating the endoscopy and or the length of stay in the hospital. Another debatable issue is the proton pump inhibitors, PPIs. Previously, pre-endoscopic PPIs were given to almost all the patients. We usually used to give, for example, omeprazole. We used to give 80 milligrams IV push, followed by an infusion of 8 milligrams per hour. But recent trials showed that it doesn't have that benefit, although it's still used in real life. But the recent guidelines said that they're neither with or against using it. Then this is a summary of the American College of Gastroenterology 2021 guidelines for upper GI bleed. They tell you to check the Glasgow-Blatchford score, and then this will tell you if you need to admit or discharge the patient with outpatient management. If you admit, you have to restate attention to active comorbidities, transfuse if hemoglobin is than 7, as we said. And then they mentioned, as we mentioned, erythromycin, and then the PPI, again, as we mentioned, no clear recommendation. Then the upper endoscopy within 24 hours of presentation, and further disposition depends on what they will find in the endoscopy. How about lower GI bleed? Lower GI bleed will need a colonoscopy, which will identify the cause in more than 70%. If severe, you need to do the colonoscopy within 12 hours. In all cases, you have to prepare the colon. What does that mean? It means that we have to clear the colon, so the endoscopist will have a clear field of vision. There are more than one protocol for preparation. One of them is using polyethylene glycol electrolyte solution, which is a laxative, and it should be started 4 to 6 hours before the colonoscopy. Then, if the hematochezia, for example, which we said usually it's a lower GI, but if it's associated with orthostasis, this means that this patient might have a brisk upper GI bleed. And you have to exclude that by doing an endoscopy first. That's the emergency. And if you don't have a clear answer, you might use a push enteroscopy or a capsule endoscopy. In some cases, it might be sufficient only to do an anoscopy, which means the scope will only advance to the anal area. In conclusion, endoscopy in combination with urgent colonoscopy will result in the diagnosis in more than 95% of the patients. What if the patient is too unstable to do endoscopy? You can consider calling interventional radiologist so they can localize the bleeding by arteriography and then treat it by intervention radiology procedure. Another thing that can be done is a tagged Rbc scan, which can identify general luminal location if bleeding rate is more than 0.04 ml per minute, while the arteriography will localize it if the bleeding is higher, 0.5 ml per minute. Then a last resort, if the patient is the patient's bleeding cannot be localized and they have a life-threatening bleed, the last resort is getting the help of general surgery and doing laparotomy. So this ends our approach. Let's take a look about the etiology of GI bleed. For upper GI bleeding, these are the list of causes. It could be a peptic ulcer disease, 20 or to 67% of the cases, erosive gastropathy, erosive esophagitis, or esophageal or gastric varices, or portal hypertension gastropathies. Another cause is vascular causes like angiectasia or AV malformation, hereditary hemorrhagic telangiectasia, Delphi lesions, GIB, which is gastric antral vascular ectasia, aortoenteric fistula, which can be life-threatening, malignancy 2 to 8% of cases, which is not a very low percentage, miliary Weisstier, Cameron lesions, or post-phrenectomy bleeding, which is a surgical complication. In this lecture, we will not go through all of these, but in the references, you can find the definition and description of each of them. How about lower GI bleed? Well, it has different causes like diverticular bleed, a polyp or a tumor, colitis, anorectal disorders, vascular causes, which is AV malformation and the ones we mentioned before, or a Michel's diverticulum. Then we will end with obscure GI bleeding. Obscure GI bleeding means a continued bleeding despite negative scope, negative colonoscopy, and the patient might have melena or hematochezia, but you can't find the source, and it's seen in 5% of patients. These are the list of the etiologies. Some of them we already mentioned before. Then, how can we diagnose obscure GI bleeding? You have to monitor, and as soon as bleeding becomes active, for example, the patient are now having a melena or a coffee ground, vomiting, or so on, you have to repeat the endoscopy again. If not, you should do a bush enteroscopy. Sometimes you have to repeat the colonoscopy only if it wasn't well prepared before, or there was any questionable area. If still negative, you should go for a video capsule, which will reach the small intestine. If still negative, you can consider technetium scan for Michel's diverticulum, or you might try a single balloon or double balloon enteroscopy. Then another options are the tagged Rbc scan or arteriography.